Hello, good afternoon. Is everybody there? Okay. Once again, good afternoon, and welcome to this session. As you heard before, that SPAGN has actually started off as a European organization 15 years ago, and 2015, I believe, Vandana, you were attending the first conference in Paris, and that was about the time when SPAGN went global. And in 2022, then SPAGN was also formalizing this process and became a global network officially. And the membership has increased from 11 countries, European countries, to actually 70 associations, I believe, in 25 or 27 countries from all the 5 continents. And as we also heard, the ambition is really to work together, to strengthen one another, to form a common voice, influential voice at a global level.
So, the reality, we are talking about involvement of low and middle class countries in the research and other protocols. But the reality is that in many low and middle class countries, they are yet to become members. That's number one thing. And there is, maybe in some countries, there is no sarcoma group present, so it becomes difficult for them to participate in it. Also, in many countries, sarcoma is a rare disease, so not too much focus. Like in India, we have a lot of focus on head and neck cancers, and we have a lot of focus on breast cancer and cervical cancer, but little about sarcomas. So those are the challenges that we have to face, but still we want people to be aware of it, because as we know that about 80% research was done last year, and out of that, only 40% were from the lower and middle income groups, which is a big disparity, because not many people from the other countries are involved in it. So I'm hoping that with SPAGN, we are able to reach out to many more countries, and we are able to reach out to them for research purposes. And the divide that is there between the sarcoma community is fulfilled. So, as far as data is concerned, I don't think there's much known about data. Maybe you can highlight some of it later on.
Well, anyway, for these reasons, we are really very grateful that for the first time we have a session on challenges in low and middle income countries, and we have this afternoon 3 distinguished speakers who will share with us now their insights and experiences.
From our co-host, the National Cancer Institute, we welcome the first speaker, the Director of the Institute of Global Health, Mr. Satish Gopal. He oversees inter alia initiatives to build capacity in low and middle income countries, and will be presenting insights from the expert perspective on challenges in managing rare disease and conducting clinical data. We will have the opportunity to ask him questions soon after his presentation, because he has a certain time limitation and he needs to go. So keep your questions ready. As soon as he finishes his talk, we can ask him questions. Thank you.
Terrific. Thank you all so much for having me. I'm new to this meeting and new to this community, and I understand this is a new topic for SPAGN, so really want to just thank you all for welcoming me, and particularly my wonderful colleague Brigitte Wiedemann, who I think, as we all know, couldn't be here today. As mentioned, my name is Satish Gopal. I direct the Center for Global Health at the National Cancer Institute in the US, and I was going to talk a little bit about rare cancer and clinical trial challenges in LMICs, and hopefully this will be useful. First, cancer is a global problem, and most of the burden is in low and middle income countries. So if we project forward to 2050, approximately 75% of deaths are anticipated to occur in low and middle income countries. That's according to data from the World Health Organization and the International Agency for Research on Cancer, which is shown on this slide. So you can see at the left in the box are low income, low middle, and then upper middle income countries, which again will bear 75% of the world's cancer deaths by 2050. Shown in the clear circles at the bottom are the 2022 estimates, and then in the solid circles at the top are the 2050 estimates. And the other thing that you will see, in addition to the fact that low and middle income countries will have most of the world's cancer deaths, is that the proportional increase over the coming decades versus 2022 are largest in the lowest income countries. So for example, low income countries will see a 150% increase in the number of cancer deaths. And this is of course occurring in healthcare systems that are already overstretched, with many under-resourced, overstretched, and dealing with many competing causes of morbidity and mortality. I've shown at the bottom as well, just to put this in context, what this translates to is more than 26,000 cancer deaths per day worldwide in 2022. And at the peak of the global COVID pandemic in January of 2021, there were approximately 16,000 COVID deaths per day that occurred worldwide. So I just highlight this not to pit one disease against another, which is of course not my intention, but rather to illustrate that because the cancer pandemic is occurring slowly over years and decades, it doesn't attract the same kind of political will, investment, attention that a communicable disease epidemic that develops much more quickly does. The other thing I want to highlight, and I won't show these data simply in the interest of time, is when WHO and IARC project forward to 2050, what they do is they take current age standardized rates, lock them in, and then apply that to anticipated demographic changes around the world. That is growth of populations and aging of populations, which principally is occurring in low and middle income countries. But that underlying assumption is actually incorrect. If you look more carefully at the ways age-adjusted cancer rates are changing around the world, we in the United States have had declining age-adjusted cancer incidence and mortality rates like most high-income countries in recent years, whereas they are increasing in many low and middle-income countries. So if you apply anticipated demographic changes and then additionally consider this differentially changing cancer incidence rates around the world, I think it's likely actually that low and middle-income countries may bear an even greater proportion of global cancer deaths going forward, even than what we currently project and anticipate. I wanted to talk for a moment about sarcoma, and so I've taken here data from the Institute for Health Metrics and Evaluation, run out of the University of Washington, showing global sarcoma incidence on the left, and then disability-adjusted life years on the right. And this is general sarcoma, right? And I think we will all appreciate that, as shown here in the incidence map on the left, that global incidence appears to be higher generally in high-income countries, which have a more intense color, and generally less frequent in low and middle-income countries. I think we can all appreciate that, as Vandana was alluding to, the registration systems, the diagnosis systems, there's probably some degree of under-diagnosis and under-ascertainment that is occurring in LMICs, which may in part be responsible for this low frequency. But even in countries that have a reasonably good infrastructure, like China, like Brazil, like the Middle East, like India, you're still seeing seemingly a lower incidence of sarcomas. On the right is shown disability-adjusted life years. And here I think what you'll see if comparing to the map on the left is the high-income countries, the color de-intensifies a little bit, and in the global south, the color intensifies a little bit. And what to me that illustrates is that even though these may be relatively infrequent cancers in the global south, they are often associated with morbidity and mortality, thus contributing a greater proportion of disability-adjusted life years to the total global burden. If you dive into these data a little bit more deeply, what you will also note, and I haven't shown this here, is that in high-income countries, much of the DALYs are years lived with disability, and in the global south, much of the DALYs are years of life lost. So it's very frequent. People are often dying as opposed to living many years with disability in the global south, and so there's a differential contribution to the overall DALY burden. So again, I think it just highlights what you all know already, which is that even though these diseases may be seen as rare, they exact an enormous burden worldwide and really touch the lives, of course, of individual people and families and societies. And I think it's wonderful, therefore, to be at this meeting for the first time. I want to talk for the next couple slides about research funding. So at the left, I've shown global cancer burden. So the same data that I showed you a couple of slides ago, that is new cancer cases and how they're distributed between low, lower middle, upper middle, other high, and then the US worldwide, according to 2022 data, which is the most recent data that the WHO and IARC have. And I've shown at the top of the slide the gross national income per capita levels thresholds that the World Bank uses to classify countries into these various categories. And you can see the US is kind of an outlier in many respects. And then at right, I've shown the NCI extramural portfolio. So most of the money that we receive from Congress each year at the NCI is given away to the peer review committee, to the cancer research community worldwide and domestically through a competitive process of peer review. And obviously we're a US government agency with a primary domestic mission, and that's reflected in our largely domestic funding portfolio. But we do have a sizable portfolio of investment that supports international collaboration. In the most recent year that we've analyzed, this is about 14% of the overall portfolio that includes international collaboration. And as shown here, this is mostly in other high-income countries, right? That is cancer researchers in the US finding collaborators, often in other settings where there's strong cancer research infrastructure and collaborating. At the Center for Global Health, we're very focused on trying to grow the NCI investment in low and middle income countries, appreciating that that's where much of the world's cancer arises, and to try to realize some of the scientific opportunities that are available through meaningful study in low and middle income countries. And as shown here, it's about 5 to 6% of the NCI extramural projects that involve low and middle income countries. This is a relatively modest part of our portfolio. It is growing in recent years, and it's about tenfold higher if you look at what the NCI does proportionally versus the average across all other public and philanthropic funders around the world. So I think we're always trying to grow this portfolio. We think it may not be enough, but I think it is fairly significant, particularly in relation to some of our funding peers from around the world. I wanted to talk for a moment about clinical trials. So what I showed you previously was NCI-supported research generally. This is now, I think, a nice paper that focused specifically on oncology clinical trials, actually from some of my colleagues in Canada. So this is a systematic review of oncology randomized controlled trials that were published between 2014 and 2017. These authors looked at English language reports of phase 3 studies that tested any cancer-directed therapy. So there were nearly 700 RCTs that were reported during this period, of which 8% were in low and middle income countries. So 51 in an upper middle income country, of which 42 were in China, 7 in a lower middle income country, of which 6 were in India, and 0 out of nearly 700 in a low income country as classified by the World Bank. And for those of us who do research, I think all of us understand that if you have a biased sample, you get biased results. And I think it's important for us to acknowledge as a global cancer research community that our accumulated body of knowledge, at least as generated through oncology RCTs, is biased in relation to global cancer burden in some very important ways, right? So it's probably a poor match to global cancer burden. And I've shown that in a figure taken from the paper at right, where you can see that some of the leading causes of cancer mortality worldwide are relatively underrepresented and not frequently studied in oncology RCTs. So for example, liver cancer, cervix cancer, cancers that predominantly affect low and middle income countries are very rarely studied in oncology RCTs. These authors additionally show that RCTs that were done in low and middle income countries actually more often identified effective therapies with larger effect sizes, that as investigators working in LMICs have to be quite strategic and don't have the luxury often of spending a lot of time and resources to identify therapies with relatively modest effect sizes. And even though perhaps RCTs that were done in LMICs were in some ways better matched to global cancer burden, perhaps more effective, more often identifying effective therapies with larger effect sizes, these authors convincingly demonstrated in data I haven't shown that there's significant potential bias likely against LMIC RCTs. They really do tend to be published in the lowest impact factor oncology journals. Before coming to the NCI in 2020, actually being recruited by Doug Lowy, who was here earlier, I spent a decade living and working in low-income countries in Africa. Most of that time was spent in Malawi as an NCI-supported physician scientist. So I led a cancer research group that really tried to invite patients and communities that had never been involved in cancer research to participate and benefit from cancer research and to generate knowledge that we thought would be valuable for the world. And most of that time was spent in Malawi. I'm not going to talk at length about this experience, simply in the interest of time. For those of you who will be at AACR, at Pat LaRusso's invitation, the Presidential Symposium this year is focused on global oncology, and I will be talking a fair amount about work that we did in Malawi during that talk. So for those of you who are there, I hope you'll consider attending. I've just shown for illustration some of the health system and social and economic and demographic characteristics of Malawi during the period of time that I lived there. So it was a country of approximately 18 million people. HIV prevalence was 9% during that period. I was the only medical oncologist living and working in the country of 18 million people during the period of time that I lived there. And health expenditure per capita was $35 per person per year on all health-related needs. I was trying to think of an example of rare cancer research that I could offer from Malawi, really in the spirit of this meeting. And the most common sarcoma in Malawi is Kaposi sarcoma, which is probably not a surprise to you, and I imagine no one here studies, because that tends to be at different meetings. But that's shown in panels C and D on that slide. So that's a lymph node, and you can see there are these spindle-shaped endothelial cells infiltrating the lymph node. So this is KS in a lymph node. And in panel D, this is a stain for KSHV, an immunohistochemical stain for latency-associated nuclear antigen, which stains KSHV. So this is KS in a lymph node. And the KS was understood because there's high prevalence of HIV and high prevalence of KSHV to be a fairly common cancer in Malawi. Indeed, in many African countries with high HIV prevalence, it's the most common cancer among men in recent years, not just among HIV-infected men, but among men generally. So there was a lot of understanding, work, research focused on Kaposi sarcoma. One of the things that we were interested in is that's not the only disease that KSHV causes. And so KSHV causes some other conditions that are much more rare, one of which is multicentric Castleman disease, which is a polyclonal lymphoproliferative disorder associated with severe systemic inflammation, also caused by KSHV. And when we initiated our research activities in Malawi, one of the things we were interested in is there's a lot of KS, but no one seems to be describing MCD anywhere in Africa. And this is either because it's not occurring or because people are not recognizing it. And the truth is, it's probably a little bit of both. When people had looked, they had generally looked in the era before antiretroviral therapy was available in Africa. And unlike basically every other HIV-associated comorbidity, multicentric Castleman disease actually epidemiologically increases as patients are treated with HIV. And that's shown in slides A and B, which is a lymph node, and it was also probably being under-recognized. So in slides A and B is a lymph node with an involuted germinal center, a rim of plasmablasts surrounding the involuted germinal center, which again stained positive for KSHV using this LANA immunohistochemistry. And so once we had an infrastructure in place that allowed us to recognize and diagnose this, in addition to now conducting studies in the period during which HIV treatment was widely available, we very rapidly assembled a cohort of patients that was comparable size to cohorts that had been assembled over many decades in the US and in Europe. And this, surprisingly, was a much more common disease than anyone had imagined, even though it had been basically unreported from the region in the years prior. And so we found it to be about 14% of pathologically confirmed lymphoproliferative disorders among people living with HIV in Lilongwe, the capital of Malawi, during this period, which is a much higher proportion than would be typical in the US, and have a lot of research activity now directed at this rare disease, which turns out to not be so rare in the Malawian environment. And I think, like the work that all of you do and the work that was described earlier this morning, I think one of the things that was intriguing to us is that rare diseases, we think of them as rare, and they're obviously so important to patients who are affected and to families and communities who are affected. But I think, as highlighted this morning, there's also broader implications of the study of rare diseases. And Doug mentioned this in describing, if you add up all the rare diseases, it's actually a significant fraction of the overall cancer population. And for us in Malawi, as we thought about this relatively rare disease of MCD, we really started to, I think about what some of the broader implications might be. One is the incidence is probably going to increase as treatment for HIV becomes more available. We think it's vastly under-recognized and diagnosed at a community level. And so now a lot of our research activity is trying to not only identify cases at the tertiary care hospital, where we've gotten pretty good at recognizing it, but trying to understand all of the people who are probably being empirically treated for TB out in the community when they present with lymph nodes and fever, but probably have MCD. as patients have been treated for HIV in African settings, there's been this persistent problem of early mortality that has been difficult to make go away. And that's largely because the causes of that are not known. And people have tried empiric TB treatment, a whole variety of things to try to mitigate that early mortality. And we don't think MCD is responsible for all of it, but it probably is responsible for a fraction. So we're trying to do a better job of recognizing those. It's rapidly fatal without rituximab, so in work that I haven't shown, we've started to apply that in a setting where it had not been previously available for these patients. And then an MCD-like condition has been described in patients receiving immune checkpoint inhibitors like atezolizumab when they are KSHV infected at baseline. So we are really interested in the problem of, as there starts to be availability of these more novel cancer agents in populations that are more frequently KSHV infected. I think this is also an adverse event that we may not have seen previously with these agents that we're going to have to monitor for. And indeed, in designing some of our planned immune checkpoint inhibitor studies in Africa, I think, which John and others have been very helpful with, have started to think about what some of these unanticipated adverse events and complications that may be very context-specific may be. I want to end for this meeting just bringing it back to patients. I think everyone has spoken about how important this is, and this is a slide where I often use to try to do this, just to illustrate Burkitt lymphoma. So Dennis Burkitt was an Irish surgeon working in Kampala, Uganda in the 1950s. And he identified these children came forward with this unusual craniofacial tumor, which he actually thought was a sarcoma, right? That was his original diagnosis. And it was only when he biopsied those samples, sent them to hematopathology colleagues in London, that this was recognized to be a lymphoid malignancy that we now understand as Burkitt lymphoma. And this led to many decades of seminal discoveries in cancer research, right? The discovery of a new oncogenic virus, Epstein-Barr virus. Colleagues from the NIH, from the pediatric oncology branch, who traveled to Uganda to learn how Burkitt lymphoma was being treated there, then came back to the NIH to use those same regimens and achieve good outcomes. So this idea that, which really underlies a lot of the principles of modern multi-agent chemotherapy delivery, discovery of the c-Myc oncogene, and all of this discovery over many decades has led to studies both in adolescents and young adults and also in children through COG studies that have basically cure nearly all of these patients with standard first-line therapy, right? So that we think of relapsed and refractory Burkitt lymphoma studies as being impossible to do now in the US. The disease is too rare and people do too well after first-line therapy. The thing that I always try to point out is the very children and families and communities who initiated these many decades of discovery have not benefited. And I don't say that just to be provocative, I say that as an empirical observation, having lived and worked in Africa for a decade, is we routinely saw children who presented just as they did in the 1950s, who got about the same treatment that they got in the 1950s and 1960s, and did about the same. And I think this is a moral failure, just to be clear, but I also think it's a scientific failure, because I think it's important that we take everything that we've learned and try to see if we can deliver a broadly deployable solution back to the very families and communities that help initiate these many decades of progress. And more fundamentally, I really think a lot about this fairly simple, but I think pretty deep and pretty philosophical question about who really gets to contribute to research and who benefits. And so at left, I've shown the 6 children photographed by Dennis Burkitt and included as 6 individual figures in his seminal 1958 British Journal of Surgery paper. And I would argue that they have contributed a great deal to cancer research, but haven't benefited in the way that they deserve. And just as counterpoints, I've shown Emily Whitehead in the middle slide, right? Many of you will know her story. It's an amazing one because it's such a powerful example of cancer advocacy and patient advocacy. She too had, in 2012, the same year that I moved to Malawi with my daughters, she had relapsed B ALL and became the first pediatric patient in the world to receive CD19-directed CAR T therapy. Nearly died of CRS. Survived when she received tocilizumab as kind of a desperation Hail Mary, and then has gone on, of course, to be cancer-free. This photo is from 2022 when she was 17 then and had her 10-year cancer-free sign, and as you know, she continues to update this every year. She and her family have a foundation. They've become amazingly important advocates for cancer research, testifying for Congress, and I think her example is so powerful because it's so clear how she contributed to and directly benefited from cancer research, right? At the right is my daughter. So this is Zuri. She's 5 years younger than Emily. So in 2012, Emily got CAR T therapy. 5 years later, in 2017, my daughter Zuri was 7 years old, just like Emily was when she received her CAR T therapy, and developed cerebral malaria while we were living in Malawi. And this is a long, harrowing story that I don't have time for today, but she got intravenous artesunate. In large part because clinical trials conducted among children in Africa and Asia demonstrated that IV artesunate was a superior therapy for severe malaria to IV quinine. She nearly died, she survived as a result, and she was nice enough to let me take this photo. In the same year that Emily posted her 10-year photo, she posted a 5-year malaria-free. And I would say I don't do malaria research, so I don't think I've meaningfully contributed to malaria research in important ways, but we did clearly benefit from these research investments and from the willingness of people around the world to kind of step up and contribute to research. The other thing I'll say is Zuri has a horse riding lesson this afternoon, and her mom is traveling, and so I have to go and pick her up and drive her, which is the reason that I can't stay until the end of the session. So I just want to thank you all again for inviting me, and I guess I'll have an opportunity to take a few questions now. Thanks so much.
Any questions? Well, then I have a question. Don't be surprised. Well, considering all the research, of course, that NCI is doing, and also your personal experiences, so what would you say that a global network like the Sarcoma Patient Advocacy Global Network could do or should do meaningfully to help and either improve the situation of care, diagnosis, or data, or research? I mean, it's like a wide open field, but maybe you have some hints.
I think it's a really good question. I guess one thing that immediately comes to mind is there is a burgeoning patient advocacy community in LMICs, right? There's quite active groups in India, there's quite active groups in many parts of Africa and Latin America, and I know some of them are already involved in SPAGN. I think in general, they just don't have the maturity that a lot of the more high-income country patient advocacy groups, they're just getting organized. First of all, I mean, it's only recently that people are probably surviving cancer diagnoses in these environments to even have patient advocacy groups, but you're starting to see them. And I think they could frankly use a lot of support and mentorship, right, for how to organize effectively, because generating that kind of political will and interest and momentum, I think, is something that is very possible, but it's going to require a sustained effort. And I think there's a lot, I think many of them would be very eager to connect with groups like yours to learn how you've been so effective at helping to drive the research agenda, because I think there's no shortage of talent. It's just developing the infrastructure and the experience that would allow them to do some of what has been done in the US.
I have one question that is related to the education level and the socio-economic status of people in the countries that we are talking about. So maybe, there's a very small percentage which falls into the higher income bracket and who would afford to go through this test and who would agree to be a part of the research. But having lived in Africa and in the countries that you've been, probably you'll know better how you could motivate the people who are not so educated and who are not so rich to be a part of the research.
So in general, I think people, I think there is a little bit of if you build it, they will come kind of, so that's been our experience, is right, we began working in a place where there was really no or rudimentary cancer research infrastructure. And I think as you have to be strategic and you can't do everything all at once and you have to build over time. But I think as you do that, we certainly found patients more than willing to participate, particularly when they feel like it's a partnership, right? When you're there, again, this is all the same things that have made the US enterprise successful. I think there's a sensitivity, for example, around genomic sequencing in many low and middle income countries. were able to overcome that because it wasn't this kind of helicopter model of cancer research where you sort of drop in, gather a bunch of specimens, send them, bring them out to a US lab, and then sequence them, and then the people who contributed don't ever know what was found, if anything was found. I think when it's more of a partnership and they can see the ways in which they're directly benefiting, but also the ways in which they may not be directly benefiting, but maybe helping to generate knowledge that is valuable for their country and for future people in Malawi or elsewhere who are experiencing cancer. I think there's actually an amazing generosity. And a lot of these things that we think of as, well, there's so sensitivity around genomic research, et cetera, if it's done in the right way, we found all of that to be surmountable, basically.
Sorry, I just want to come in on this. You know, it's a misnomer that clinical trials and the patients and the communities that are in these countries do not accept clinical trials. A misnomer, and it needs to be killed. Because I'll give you an example. My country ran the biggest clinical trial for COVID-19 in the world. 53,000 people, okay, in the country I live in Africa. 53. Now you tell me that that cannot be replicated in other diseases. We have the ability to do it, we have the infrastructure to do it, and we have the people willing to do it. So what is the problem? For me, it seems like will and focus. It is a misnomer that patients will not. We do not have the stigmatization of clinical trials like they are in the other countries. We do not have it in our countries because those people are desperate for anything. Because they don't have the treatment otherwise. Basic treatment. Liver cancer. Diagnose the virus that looks at liver cancer, HPV-B. On that, was defined in South Africa. When a patient is diagnosed with liver cancer, they are palliated in South Africa. South African doctor defined what that virus was. And yet, our patients today die. And I'm not talking about normal palliative care, I'm talking terminal, end-of-life care. It's a misnomer. The issue is not that. It is funding, it is political will, and it's just the inclination to do it.
Okay, so thank you very much, Dr. Gopal, for your presentation and answering the questions. I think it was great. And don't forget your chocolate.
Great,
Thank you very much. Yeah, okay, sure. So, and I think I was going to introduce our second speaker. I think she has introduced herself already very well. This is Lauren Pretorius from South Africa, the Chief Executive from Campaigning for Cancer, and Lauren has been providing really very critical inputs also to the development of a concept of Sarcoma Intelligent Specialist Networks as a concept that would also maybe be applicable globally, not only in more advantaged countries. And she's going to talk now about the challenges in her country and the applicability of the concept. Thank you, Lauren, please.
Hi, I clearly upstaged myself. So, apologies, I'm a walker on the stage, so if I start swaying, just... we were involved a few years ago, I think we were sitting, it might have been Rome, or no, it was before that, where we were sitting in a meeting similar to this, and we started talking about specialist treatment centers. Or it was, and one of the things that myself and Vandana came up with was that your geographic specialist treatments and areas don't work in countries like ours. And fundamentally, this group of people changed their minds and presented a piece of paper that was, in terms of patient advocacy, groundbreaking. It was the first time a group of people who really didn't represent very well low to middle income countries changed their thinking on something and published it. So, in South Africa, I'm often asked, what is the advancement of medicine and what does it mean to patients? And I take this to think. And the question is basically nothing if they can't access it. All the money we spend in research, all the hard work we do, if it does not reach the patient, it does not matter. You might as well have not done it. So all our time spent at the NCI and that is wasted if you don't have it. All those billions of dollars wasted because of patient. So this, I want to talk about innovative thinking, because we have a group of innovative thinkers here, clearly, as we've seen. This is Gabriel. Okay, Gabriel's my nephew. He's 6 going on 36. Often we hear the words, because I am the parent, you are the child, spoken to him. When he grows up, he wants to be a soldier, although last week he wanted to be a scientist. What will he actually be when he grows up? A lawyer. You can get lawyered by a 6-year-old. But the most fundamental thing that I love about Gabriel is when you ask him what his favorite animals are. A bunny and a creepy crawly. Now, I realized I'm presenting to an international audience, so let me explain. In 1973, because we're fundamentally lazy and look for the easy way out, South Africa created what was called the creepy crawly. It's the thing that sucks up the leaves at the bottom of your swimming pool. Okay? That is Gabriel's favorite animal. So the innovative thought of 1973 has become alive and understood by a child as a living thing in his life. When you try and explain to Gabriel that it's not a living thing, he looks at you and says, but of course it is. It lives in the water, it eats the leaves, and when you take it out the water, it can't breathe. It goes like this. Now, I'm not going to fight with that. Gabriel has access to every 1.0, 2.0, and 3.0 creepy crawlies, as you can see. But the question I was asked, and I want you to carry on thinking about Gabriel, because we started off with some innovative thinking, and I want us to carry on thinking. But I'm going to give you a little bit of the lay of the land. So, what is something like an intelligence network available would it work in South Africa? So I'm going to ask you to I'm going to give you the lay of the land, then you tell me. So South Africa has 2 healthcare systems. We have a publicly funded, that's funded through general tax, out of our SARS. There are 9 provinces that do it, and 1 national of health. It does the primary care, hospitals, and it's considered a public sector with salaried employees. We have private healthcare. Individual and employer contributions. There are medical schemes. Here it says 119 at the moment. There are 93. And these are fundamentally medical insurance companies. Okay? You buy a set of regulatory and formularies and protocols through managed healthcare, and you have access to that according to what you can pay. Sounds familiar to some of your countries. Here's the difference about South Africa. These 2 never touch each other. The hospitals are separate, the medicine is separate, the doctors are separate, and never the 2 shall touch. In fact, if you have what we call medical aid, medical insurance, okay, you may not access the state sector. Okay? Everything is done in this sector through fee for service. Only 16% of the population allow for that 8 million people. 8 million people out of South Africa have access to that insurance. And it's pretty good. It's first world, it's high income. We have access, access to most of the stuff. The rest of the 85% form part of that state sector, and it's done through essential drug lists. Trastuzumab, the first targeted therapy, is not on the essential drug list. Okay. Half of our country's spend is spent on that, GDP spend on health resources is spent on the 16 million. Okay. By this you can see that we are the most inequitable country in the world. We have a national cancer strategic framework. Those are the 5 cancers that the state sector is willing to look at. Nothing else. 2, if you are diagnosed with renal cell carcinoma, you are sent for palliative care. Okay. I've highlighted, this is a audit that we did of the state facilities in 2022. I'll highlight the orange highlighted, and I don't know if you can see them, but the orange highlighted are the 7 main hospitals in the country that have tertiary. So everything is primary, tertiary, secondary through a referral system. Okay. Scary thing is, if you have a look here, about the sufficient and insufficient that allow and sit within those things. Now I ask you, would a network work in a situation like this? But we have a plan. Well, sort of. We have universal health care. That sounds like a good idea. So what we'll do is we'll pass a national health insurance bill. But what we'll do at the same time as the national health insurance is pass the bill, but not figure out how we're going to pay for it. So we have a bill gone through Parliament, but no one's figured out how we're going to pay for it. And when they do the math, to pay for it will cost more than the GDP of the country. Needless to say, this has not been well received, and it will probably spend the next 15 years in court and be litigated. But I want to take you a little bit north to our neighbors now, because I want to talk to you about a story of privilege. So as Campaigning for Cancer, we work in South Africa predominantly, but often a patient will come over from one of the neighboring countries. And this is generally how the referral happens. Tell me when you can talk about this, please. So I'm going to tell you where the privilege comes in. This was a WhatsApp from my sister on one of her employees. That was her business partner telling us where can we do that, what is happening and where can we speak to it. And this is the result of Enoch. And Enoch is privileged to live in Zimbabwe. He's 28 years old, he's employed. He has access to some sort of private healthcare because my sister's company make sure that their staff have that. And when he had to pay for cash for the histology report on his, the company paid for it. Enoch, as I said, he's a technician. He fixes most of their, they work in restaurants and so on, and he fixes most of their machines. But Enoch's had a lump on his hand for 10 years. And when he came to speak to me, he said to me that he'd gone to the doctors because he thought there was something wrong with him, but they told him that he'd bumped his hand because he works manually. And it was just swollen. And then he must have broken it at some stage, and it's a little bit of calcification. Needless to say, he was sitting with a sarcoma. By the time I saw him, again, Enoch's privilege, because I'd gone to visit my sister and she'd basically told me I had a meeting with Enoch at 7 o'clock the next morning. Enoch had been told that he'd have to have most of his middle finger and hand removed. Okay. The doctor, because he'd gone to a private doctor and was able to pay for it, picked it up. And the histology was sent to South Africa, or Lancet has a satellite office. This is Enoch's story of privilege, where fate came together to save Enoch's hand. But when I sat down with Enoch, I wanted to know, because in South Africa, we're told that things like stigma are an issue, and that no one hears about this, and that the church would take Enoch and ostracize him. So I sat down with Enoch and I said to Enoch, Enoch, what's the problem here? Tell me. He said, well, he just wants to know, can he carry on working? That's all he wanted. So I said to him, well, Enoch, yes, the fact that your doctor found this was so lucky that you have a true chance of doing that. It took Enoch 3 more weeks to decide, because there was no one to support Enoch on that. But what I did was I linked him up with WhatsApp with one of our navigators in South Africa, and Enoch had support. And then I sent an email to our colleagues, and I asked for some assistance. And I was given back the members of this room to speak to. And it got me thinking to that network. It got me thinking to how we've spoken about a network of intelligence specialists and centers. But Enoch didn't have someone to talk to. But after some time we managed, and 2 days ago Enoch had his treatment and he had his surgery. And I'm glad to say he's doing very well. But it takes me to my core when I think to myself, Enoch's site of privilege is because he works for my sister. And she could WhatsApp me the report, and I could talk to him through it, and I could speak to his doctor, and I could link him up. That's what Enoch's privilege is. Nothing else, just not what he knew, but who he knew and where he's found us. Enoch's privilege was just fate. So now we speak about Ubuntu, and don't worry, I'm not going to get on a high horse and a tirade here. In South Africa, we have a saying called Ubuntu. Ubuntu means I exist because you exist. In other words, we are intrinsically linked as a community. We are intrinsically linked as humans. And as we see what is happening throughout the world, and we look at globalism trying to take its way, being seen as something bad, and nationalism, I say as patients we need Ubuntu, because there will only be success in a network, in a specialist network, if we look at sarcoma patients as humans. And not globalism and a global thing, but a human, Ubuntu, to look at it. So can a specialist, a Sarcoma Intelligent Specialist Network work? It can. I can tell you, when I presented this to the South African Medical Association, they took this and wanted to apply it to other disease areas because no one had ever shown them the thinking of this. Okay? They knew about the thinking, but they'd never been shown on an international level patient groups that had sat down and said, hold on, let's think about the 80% of the world, not the 20%. Let's think about the global south. But in order for this to work, to make sure that Enoch's privilege is not because my sister employs him, we need to do some things. We as patients need to create a support for this intelligence specialist network. We as a global group should be creating a global network of patients, because there are too few patients for me to create this in South Africa on my own. I don't have the funding, I don't have the resources. Enoch's country does not have the funding, he does not have the resources to do this. We don't have specialist nurses. A navigator, a lay navigator was the person that helped Enoch. So that's something we need to start looking about. How do we create lay navigators for sarcoma? We have to start linking specialists to these interest groups, actively looking for specialist interest groups and looking for these doctors in these countries. They do exist. That doctor was the one person after 10 years who diagnosed Enoch. She's a person to look for. We need to record the clinical data. You heard beforehand how clinical data from other populations can sometimes change things for patients. And we need to look at how we facilitate patient groups and support groups. So my question is, yes, one more slide. So my question is, will a Sarcoma Intelligent Specialist Network work in countries like South Africa and Zimbabwe? Yes, if it's supported by a patient network. A patient network that can tell us where to go, so that the moment Enoch is diagnosed, we can funnel those patients into a global network of patients that can support him. So, I'm going to give you back to Gabriel again. Hopefully, our innovative thinking can continue to make these kinds of networks a reality, so that we can make sure that patient care becomes accessible, and that the idea of a creepy crawly one day can be for patients like Enoch as real as a creepy crawly to Gabriel. Thank you very much.
Thank you very much.
As usual, we've got a lot of food for thought, and I think we should all think about doing things as Lorena has suggested, and maybe come out with something really positive for us at SPAGN to be proud about the new initiative that we've taken. Finally, we have Mr. Fernando Campos. Please come. He's a medical oncologist in the Camargo Cancer Center in Sao Paulo. He's specializing in the care of sarcoma patients. His research focuses on soft tissues and bone sarcomas. His goal is to reduce discrepancies in sarcoma care across different countries. And he's going to talk about the local reality of sarcoma care from his Brazil experience. Welcome, sir.
Okay, thank you. I'm truly honored to be here today to share some insights about the reality of sarcoma care in Brazil. As you know, sarcomas demand highly specialized care, and delivering that kind of care in a middle-income country like Brazil comes with many challenges, but also lessons and opportunities. Let's start setting the stage and go to Google Maps. Here is where we are right now in Washington, and here is Brazil, this huge and I would say continental country in the South America, but it is also a complex country. Let's zoom out a little bit. Brazil is divided into 27 states. We are more than 212 million people. We are not evenly spread out. As this map shows, most of the Brazilians live in the southeast of the country and in the south. And here is São Paulo, the most populous state in the country and where I live and work now. Brazil is a diverse and heterogeneous country. We have breathtaking landscapes like Rio de Janeiro. We have many beautiful beaches. We also have amazing food. This one is from Minas Gerais, the state where I was born. In my very biased opinion, it's the best food in the world. Better when I cook it. You are invited when coming to Brazil. And we are also known by our culture like Carnival. But of course, behind all this beauty and this joy, there is a more complex reality, because Brazil is a deeply unequal country, as we can see in this graphic from the World Inequality Database. The red line representing the 10% richest Brazilians. They hold approximately 60% of the country's total wealth. But why am I bringing all this up at a sarcoma conference? Because all this inequality reflects directly in our healthcare system. The same in South Africa. we have our healthcare system in Brazil is divided into two parts. There is a public system, the Health Universal System, we call SUS. About 75% of the population relies only in SUS to get any health treatment. The rest, 25%, pays for a private insurance. This is not evenly distributed across the country. Some states like São Paulo and Rio have about 40% of the population paying for a private insurance. But in some areas, mainly in the north, the northeast, less than 10% or 5% of the Brazilians can pay for a private insurance, and they rely only in the public system. And here is a striking fact, because although SUS is responsible for the treatment of most of the Brazilians, only 44% of the total health expenditure in Brazil take place in the public system. Let's focus now exclusively on sarcoma care in Brazil. I will list some issues, and the first one, and one of the most concerning ones, is that we don't have a national sarcoma registry. Our National Cancer Institute, we call INCA, they publishes every 2 years a report about the incidence of the cancer in Brazil. This one is the last one from 2023. You can see the table. It's in Portuguese, but you can believe there is no sarcoma listed. The cancers are listed according to the location of the tumor, and sarcoma data are computed as other topographies in a mixed group with other low incidence cancers. So basically in Brazil, data about rare cancers come from hospital-based registries. We know there are some problems with that because institutional databases are not homogeneous. The population covered is limited to the hospital area, and there are many cases of duplicity. Few studies have attempted to describe the epidemiological profile of sarcomas in Brazil. This is one of them. The authors analyzed the 3 Brazilian national databases, and they could analyze more than 66,000 patients. But when we look to the results of this study, we can see how fragile are the information coming from this database, these national databases. Let's see, for example, the sarcoma anatomic location. We can see that the most common location of the tumors is listed as head and neck, 23%, which is of course a little bit odd. And when we see the tumor grade at diagnosis, more than 90% it is indeterminate, and the clinical stage is also undetermined for about 80% of the cases registered in these databases. In this study, the authors, including only patients with complete staging and grading, could found a median overall survival for sarcoma patients of 42 months. In our group at AC Camargo, we looked specifically, we did this recently. We looked specifically at this Oncocentro Foundation of São Paulo, FOSP. This is an institution managed by São Paulo State Department of Health, and it's probably the most reliable source of information because this institution, they collect data every 3 months. They use the same form for the hospitals that contribute with the cases, and they consolidate the data. That means they exclude the duplicate information, duplicate patients. And more than 70 healthcare institutions in the state of São Paulo maintain cancer registries and contribute to the FOSP database. Most of them are SUS-affiliated institutions, but there are some private ones and some mixed ones like ours. So we could analyze more than 3,500 patients. Most of the sarcoma cases were of liposarcomas and leiomyosarcomas, which is in accordance with the literature. And we found more than 40% of patients diagnosed in stage 3 or 4. We also found a median overall survival in this study of 49 months. Of course, varying according to the subtype of sarcoma. Another issue in Brazil is that we don't have a centralized sarcoma care. And this is the pathway for a patient with cancer in the public system. that means 75% of the population, is the same irrespective of the cancer type. So the primary care is the entryway for the system. This primary care network is important because they play a role in promoting health, preventing and tracking cancer. It's formed basically by the family doctors, the multidisciplinary team, and the community agents of health. So if there is a suspicion of cancer, the patient is referred for the secondary care where further investigation is performed, basic imaging tests, biopsy, and if the cancer is diagnosed, the patient is referred for the tertiary specialized care where the disease is staged and the treatment initiated. The tertiary specialized care is a high complexity and comprehensive care. It's formed by accredited health institutions, public, mainly public, but also private ones. And the institutions are categorized in three types. There are the oncology centers, we call CACOM. There are the oncology units, UNACOM, and there are the hospital complexes, which are general hospitals with cancer services and radiotherapy services. The oncology centers, the CACOMs, are the highly specialized centers for cancer treatment. UNACOMs are more simple units, but they can treat the most prevalent types of cancers. There is a law in Brazil that says that the interval between the diagnosis of the cancer and the start of the treatment has to be no more than 60 days in the public system, of course. So in Brazil, we have about 360 centers for cancer care. Most of them are UNACOMs, the most simple ones, and the CACOMs, the highly specialized ones, are about 12%. They are distributed in the country, across the country in this pattern as shown in this map. The problem here is that CACOMs, although they are certified cancer centers, they cannot be considered sarcoma specialized centers. Because as we know, there are some principles for a unit, a center, to be considered a sarcoma specialized center, and this is important because patients treated in specialized cancer centers have better prognosis, and this is associated with cost saving. In a country like ours, this is a matter of importance, of course. Another study that tried to describe the epidemiological profile of sarcoma in Brazil is this one. They collected data from hospital-based registries, analyzing about 50,000 cases. And I would highlight two important informations coming from these results. One is that if we see the type of the center where our sarcoma patients are being treated in the public system, less than 50% in total are being treated in CACOMs, which are the highly specialized centers. And this varies according to the region of the country. Another information is that about 40% of the patients will take more than 60 days to get the treatment started after the biopsy, after the diagnosis, I mean. When we look again to the results of this study, there is another thing I would like to highlight here with you, because although there is no consensus about the minimum volume for a center to be considered a reference for sarcoma care, and different thresholds are used, varying from 70 to 100. If we assume the volume threshold of at least 7 patients per year, only 7 CACOMs, that is 15%, could be considered a sarcoma specialist center in Brazil. I would also add to this decentralization the geographic barriers to access in a huge country like ours. As we can see in the graphic, more than 50% of the patients has to commute to undergo any kind of cancer treatment. There are hubs and attraction poles of oncological care in Brazil, and the average distances traveled by cancer patients can reach 5 kilometers, 1,000 kilometers, especially in the north of the country. We recently looked to our data. This is going to be published pretty soon, but we tried to describe the disparities between the private and public health systems in our center because we are a mixed unit now. And our patients coming from public health insurance, they present higher lesions at diagnosis and also more metastatic disease. We also looked to that data in the FOSP database in this other project, and we found that patients treated in the public system present worse overall survival when compared to patients treated in the private healthcare system. Of course, I couldn't go without mentioning the low participation in clinical trials. I totally agree with what Lauren said before, but I would add that we have some homework also to do because there are many regulatory barriers in the country which reflects in delays in trials approvals and also increased costs. And the limited availability of patients' registries and comprehensive epidemiological data could also be a barrier to that. And there is inadequate funding. We can see in this graphic from UNESCO the percentage of GDP invested by some countries in research and development. The United States and Germany here with about 3.5% of the total GDP. Brazil, a little more than 1%. And this reflects in this picture. In 2023, we had only 8 active recruiting sarcoma trials in South America. Oh, sorry. So, but amid all these challenges, of course, there are opportunities and actions to do and to improvement this scenario. I listed some important actions, I think, here in this slide. So develop a national sarcoma registry, to institute a sarcoma care hub and spoke models to improve referral efficiency. In a huge country like Brazil, it seems that this model, the hub and spoke, would fit in perfectly because it would allow one more specialized unit to receive cases for pathological reports or maybe receive patients for surgery, and then patients continue the treatment in more simple units, which would be more close to their homes. Create national guidelines and care protocols, strengthen education and awareness among general practitioners, foster more public-private partnerships, support and scale up patient advocacy initiatives, use telemedicine to bring expertise to underserved regions, encourage the inclusion of sarcoma patients in clinical research, and build regional centers of excellence and multidisciplinary teams. There are some things in progress. Most of them are being driven by the CellNet project. CellNet means Sarcoma European and Latin American Network. It's a collaborative network funded by the European Union through the Horizon 2020. It brings together sarcoma experts and institutions across Latin America and Europe. And it aims to enhance sarcoma treatment through the creation of networks. Because of CellNet, local sarcoma groups were established in Brazil and also in Argentina now. We have more than 5,000 cases registered in the CellNet clinical database, and transatlantic tumor boards are now a reality. They occur monthly. We can discuss challenging cases every month with experts from Europe, other colleagues from Latin America, and also some colleagues from Miami. Jonathan Trent, I don't know if he's here now. He's also joining us. We have our first Latin America guidelines for sarcomas published recently. There is one for soft tissue sarcomas and GIST, and another one for bone sarcomas. And also, I would like to highlight the crucial role of patients' advocacy groups in developing countries like ours. We recently published our opinion on this and our discussion about the importance of patient advocacy groups in our countries. In Brazil, the first group of patient advocacy was founded in 2021 in this field of sarcoma. It was the Desmoid Tumor Brazilian Association, which is now Desmoid and Sarcomas Latin America. And I must highlight the important help and encouragement that SPAGN could provide in this process. I listed some important actions, front of actions that patients advocacy group can play in countries like ours. I would say that Desmortem Sarcomas Latin America Patients Advocacy Group can now represent patients' interests and needs pretty well in our country. They have many educational and awareness activities. They can provide emotional and peer support to patients and families. They can help navigating the patients in the health system, and also are contributing in building networks and collaborations. I would say we are still struggling with research collaborations and policy advocacy. Well, as you saw, there are many challenges, but I don't think we need to wait Brazil to improve the economy, to resolve the inequality, the disparity between the private and public system, because high-quality care can be delivered even in resource-constrained settings with coordination. I would like to give special thanks here to Dr. Javier Martín Broto, medical oncologist from Spain, for his outstanding leadership and commitment to sarcoma care in Latin America. His work through the CellNet project continues to inspire collaboration, improve knowledge, and build bridges across our region. I would also like to thank Professor Bernd Kasper for his tireless work advancing sarcoma care worldwide and fostering international collaboration. More than a global leader in the field, he has also been a generous mentor to me through the CITUS mentorship program, always encouraging, guiding, and believing in my potential. I first met him in 2022 at CITUS Vancouver, and every CITUS meeting I take a picture with him. This one is in 2023, the other last year in San Diego, and this will be us at CITUS 2059. With that, this is our groups, our Sarcoma and Bone Tumors Reference Center at AC Camargo. Thank you all for listening, for your time. Thank you.
So thank you very much to both of you for these reports from Brazil and South Africa. I mean, the challenges seem really overwhelming, but at the same time, I also want to thank you for giving us here also perspectives, maybe some ways like on how one could start certain improvements in this way. So I wanted to ask, do you have any questions to our two speakers? No, don't make me ask another one. Please. Okay, please.
Thank you for
Wait.
Campos. I really like, your. Thank you for a great talk, Dr. Campos. I appreciated your idea for the hub and spoke for something that's so, needs a lot of multidisciplinary and specialized care like sarcoma. Is that something you've successfully managed to, or made progress in, implementing such an approach? Are there any particular challenges you faced in terms of creating that coordination or the trust between all the different, groups of people who need to?
Yeah, actually, this is not implemented in the country yet, but it is a model that's the CellNet project used to inspire us and try to show how we could better organize the sarcoma care in the country. Actually, we at AC Camargo are managing a project to try to see how this model would work with some institutions from the public system, using like our center as the hub. We would receive patients or the samples for pathology review and use telemedicine to guide treatment in other institutions around the country. So.
Thank you.
No, I don't.
Thanks for that excellent talks, and as I think about SPAGN being a global network, what more could we do as we begin to want to be more inclusive globally of, it seems so overwhelming, Dr. Campos, you spoke to that you thought SPAGN was helpful, but there some things that you can point to that we can at least begin to grasp and use as a jumping off point? Because it does seem somewhat overwhelming, because there are so many needs, and yet you speak to so eloquently how you've overcome quite a bit to make progress.
I think there's much already been done. The simple fact that I'm here and there are people from the Sarcoma and Desmoid Latin America advocacy group of patients here is also something really important to us. I don't know how could SPAGN help in trying to improve the thing of the clinical trials in countries like ours, because this is something that we are struggling and we don't know how to start acting on that. But I would like to hear from you if this would be possible. Yeah, I don't know.
So I think one of the things that often when we present our countries, you say it's overwhelming, but it's not overwhelming, it's life. It is what it is. And I think that's where SPAG could come in, is understanding what it is and helping us find those solutions. And I'm not talking about solutions of, implementing MRI machines and things like that. I'm not talking about those solutions. It's about changing the mindset of that and understanding that, these are rare diseases. The patients are few, but that as a global coalition or global network, both on a clinical side and on a patient navigation, and that's what you can look at, is that coordination. Because those patients, we don't have the luxury of the breast cancer and the prostate cancer, where there's a patient that, as you turn around, there's a patient that'll help you. You don't have that on that. So it's not overwhelming, and I think that's because it's life. But the one thing the paper that was presented and that change in mindset, it was absolutely, when I went to the South African Medical Association on this, they took that and put it into other disease areas. Now, unfortunately, it's because sarcoma is not a priority area in South Africa from a public health point of view. But as an advocate, I can use that, because I can say, if you learned this and you're doing it into, why are you not doing it for sarcoma? So I can use that as an advocate, because I can show that sarcoma people are thinking about out of the box and thinking about patients in our communities and in our situations, and how do we solve those problems. And there are a lot of solutions that we've created ourselves that often could help high-income countries. But that's something that I think as a group and as a network we could look at. And I belong to a lot of patient coalitions and networks, because we're pan-cancer. But I can tell you now that this was one of the things that came out, was this thought change, and it only happening in a few of the coalitions at the moment. Vandana and I were just saying, it hasn't happened in other coalitions like that. So that's already a beginning start, or a beginning.
If I hear you correctly, continuing the conversation and having the dialogue and understanding each other and finding those opportunities to
I think it's more than the conversation. I think it's putting it down on paper. So the publication and that, because that's what we can look at. It's looking at the spoken wheel and saying, okay, well, that's something we can look at, and that it's putting it into publication, giving it gravitas, so that can be done for patient advocates, and patient advocates can look at that. And then also looking at, Satish was talking about that there are immature advocacy groups in these countries. They are immature advocacy groups, but it's not because they don't understand, and that they can be taught. It's merely resources. It's resourcing. That person works. He has to work. So Enoch would be he's well-spoken, He's a really good patient. He had understanding, great health literacy after he'd listened to his doctor. He had intelligence questions to ask me. But Enoch has to work. So Enoch's not going to start a patient organization because he has 6 other orphaned siblings that he's supporting on his one wage. So that's not going to happen.
Thank you.
Any other question here? Okay, then maybe I want to ask one final one. So, because you have both explained, like also what kind of activities we're talking about the case in Zimbabwe, for example, and you have your plan actually mapped out on how you would want to improve the situation. Now, what kind of collaboration do you think you would need from other member, maybe not now SPAGN, but also other member organizations, and what kind of collaboration could you offer to other countries, like also low-income countries? Because actually we are growing as an international organization, but there is no yet, as of now, there is no low-income country a member of SPAGN.
I think that raising awareness about our existence for clinical trials, for example, and we can contribute with patients, samples. I think that's this.
Okay. I think also, this is going to sound a little bit cowboyish, but I have to. So we deal with a group of hematologists when it comes to blood cancers, and they have created protocols for patients when they don't have the drugs. They've created those protocols. Those protocols don't exist in the NCC guidelines and ESMO and that, but they've seen it's worked. And they've published on some of it, but that's some of the things that you can look at, and that's what these doctors are doing. You have to be innovative in resource-constrained areas, and it's great to treat someone when you've got a list of drugs that you can throw at it. But when you haven't got that list of drugs and you haven't got an MRI machine that's working and you haven't got the pathology and that, what do you do then? And that's learning that you can have it. Because something that, when you start looking at value-based care and how we're applying what we're applying, they were talking about downstaging. You were talking about the HPV and just downstaging, down dosing on that. That's conversations you can have with these doctors because they're doing it already. I sound cowboyish when I say this kind of thing, but it's something there is information to be learned in these resources, low resource settings. And I think that we can make better healthcare for patients when we take everything into account, because we're not taking everything into account at the moment.
Can I add something? I know that SPAGN is doing a lot of social media work now. And so if we can talk about the low resource countries and the low middle class countries and talk about what they need and what can be done. Maybe, somebody will come up as an advocate, somebody will come up as a supporter, somebody will come up with some new ideas, and the whole project or the whole problem will be understood by many more. And I think that could be the start of a humble beginning from SPAGN for helping the low resource countries and the middle class countries. Do you agree?
Yeah, totally agree.
You want to add something?
No.
So there's a lot of things to be thought about, and we'll give you an extended break so that you can talk about this problem and this issue and challenge. And hopefully by next year, when we have our next meeting, we'll have some more ideas. And I think even if we get ideas in between the 1 year, we should be able to send it out to the group, and then it can be circulated and worked on. So thank you very much for being here, and I would like to thank speakers.